beginning, what I would like to do is thank people who are not on the program. Lona Hamashoy for all the work she did in the background that most of you will never recognize. And Christine Handley and Alex Gary for all the help they gave me by email and setting up the program. No conflicts of interest on this one. This is an illustration commissioned by the New York Times for Katie McLaughlin's article, Our Relationship Thrives on Missions. The purpose of this was to demonstrate how a couple cooperated together and worked better together if they looked at a project together and worked on that project. But when this was republished in the Memphis paper, it came out in black and white. How many of you see in that picture what I saw in that picture? It completely throws me off as far as the article because I don't see that. I don't see it as a cooperative picture. I see it as this one. I mean, jump straight to it. If you look at the black images, it's faces. If you look at the white images, it's a vase. I see perceptual differences between a couple. I had to read the article twice to catch on to what it said. Perception gets in the way. Associations, previous associations, things we think we know, interfere with what we're doing. The Industrial Revolution from 1760 to 1820, 1840, depends on which version you believe, is over. And at the end of the revolution, do we have anesthesia machines? No. Do we wash our hands? No. Do we have Listerine? Has Joseph Lister come around yet? Not yet. We sure don't have hysterectomies. We're nowhere close to laparoscopies. And Robbie the Robot's not around. So we begin about 1842 with anesthesia. We don't have effective anesthesia until 1842. We have Oliver Wendell Holmes who predisposes Ignaz Semmelweis in publishing puerperal sepsis and problems with puerperal fever. But Oliver Wendell Holmes, we don't catch on to the fact that he's part of this paper. Why? Because he develops a career as a poet and the father of a Supreme Court justice. We know him not as a physician, but as a writer and a father of our country. On the other hand, Semmelweis doesn't understand that he's not Don Quixote, Kurt Sims, or any of those other people who fight the institution. So he knows he's right, he's going to prove it, and he goes down in history as losing the fight, which comes up later by 1862. So 10, 20 years later, Louis Pasteur finally realizes we have bacteria. And now we get Joseph Lister in 1867, who begins to use carbolic acid in surgery. All of this results in an explosion of surgery. We get Walter Burnham from the 6th Massachusetts. You have to remember, for those of us who are from Georgia, the 6th Massachusetts is okay. They did not burn Atlanta and march to the sea. For those of us who are Georgia, we have a completely different view of history than the rest of you. The purpose of the Civil War was that so Sherman could burn Atlanta, march to the sea, so that Margaret Mitchum could write Gone with the Wind, so that Vivian Leigh could get the Academy Award. It's all about Vivian Leigh, okay? So in 1853, he operates on the first woman to survive a hysterectomy. The story goes he thought he was removing an ovarian tumor. She threw up on the operating table, pushed the uterus out. He couldn't get it back in, so he did a hysterectomy. She survived. 10 years earlier in England, the patient did not. Then we come to Rokitansky. Rokitansky is doing anatomic pathology. He's doing autopsies. We lose a lot of his work in endometriosis because he doesn't call it endometriosis. He calls it cystosarcoma and other terms that sound like cancer. Ivo Brozin doesn't even believe he's going to talk about endometriosis because Ivo thinks it's a cancer, and Ivo knows it's not a cancer. Ivo wants the one who first describes the flowing nature, who is Cullen. Most of us go past Rokitansky into the terminology that he used. The first 4 are Rokitansky's terms. The second one are 1860 to 1920. And then we get into endometriosis and all those other things that we come from John Sampson. If we look at normal anatomy, to remind everybody what I'm going to be talking about, uterus is in the front. Cervix is hidden on this view because the uterus is tilted back, but it's up behind there. Uterosacral ligaments on either side. Rectum down low. Remember, the rectum is basically retroperitoneal. So when you look below, if it's retroperitoneal, it's rectum. If it has a mesentery, it's sigmoid. And then the sigmoid colon. And in between all of that is the pouch of Douglas. The pouch of Douglas goes down into the middle third of the vagina in 93% of women. If it did not do that, the posterior colpotomy on a vaginal hysterectomy would go into the bowel. So all of you, those of you who've done vaginal hysterectomies, you know that's true. Otherwise, you couldn't just cut through the posterior colpotomy with the degree of ease that it is. Right behind that is the rectum. If we draw a line across the middle of the cul-de-sac, we can pretty much assume that anything above that line, which is anterior, is going to be either vagina or cervix. Behind that line is going to be rectum. We don't want to operate posterior to that line, unless you mean to be close to the bowel. And then way back behind is the sigmoid. And you can tell the difference between the rectum and the sigmoid because the rectum is basically retroperitoneal. Sigmoid's intraperitoneal with a mesentery. Most of the talks we've been talking about in the last day or two have been deep infiltration with complete rectovaginal obliteration like this. Remember the previous thing, we had a cul-de-sac. This one, uterus is up front, cervix is behind it, rectum is right there, uterosacral is on either side, and that is just flat as a board. Cul-de-sac's gone. In between it is the endometriosis. So this is basically obliterated disease. This is what I was trained on. This is what everybody in my generation was trained on. This is what we learned from Cullen in 1917. Before Cullen was first publication is in Lockyer's textbook in 1917. Cullen in 1917, Lockyer. All of those were contemporaries. These are the guys who we get most of our surgical understanding from. If you notice on all of those pictures, the vagina is below the lesion. And we'll come back to that in a second because it has to do with miseducation that we all have. The endometriosis in the first one is basically rectocorporal. This is a lesion extending from the bowel to the whole back of the uterus. It goes way past rectovaginal. It's one of the tougher things to handle. Now, if we look at two other Cullen illustrations from 1917, on the first one, we have the cervix right there, rectum behind it, vagina underneath that, the lesion in between us, and what's missing from the illustration that he says is there? The septum. It's off the picture. It's nowhere close, in spite of the fact he wants to say this is rectovaginal septum endometriosis. Septum's way down below that. To make it even more obvious, he calls this one rectovaginal. And if you look at that, above that is what? The vagina and the cervix. Below that is what? The rectum. Except in this picture, it's got a mesentery, so it's sigmoid arising from where it shouldn't be arising from. But that's rectum in a normal situation. So then we go back to illustrations we've seen. If we look at my paper in 1988 and Enoff in 2001, we both had a picture that was very similar to Damian's picture and the other pictures. We draw the septum occurring right behind the cervix. I think that's rectovaginal. Leela Damian in 1993 publishes a retrocervical staging system that changes some of that. For those of you who don't know Leela, this is Asya Stefanian's mother, Asya's Surgical U. So Surgical U, which is now run by the AGL, this is her mother, Moscow. So she publishes a retrocervical stage where stage 1 is retrocervical or vagina with no vaginal involvement. It's the reason that Enoff and I were able to do what we did laparoscopically, and that is core those lesions straight through the vagina without ever touching the rectum. So in stage 1 and 2, you have retrocervical involvement, vaginal involvement, but no rectal involvement. She's still got the same error I've got. If you look, she's drawing stage 1 with the cul-de-sac that's behind the cervix. This thing's supposed to be down in the middle third of the vagina. It's not supposed to be that high, so that illustration's off. Philip Konix and I made the same error. We drew our infiltrating type above there. We drew our retracting type. And then the one that we weren't sure wasn't really adenomyosis. All of these, we've got the septum in the wrong place. If you look at Philippe's paper, Philippe's illustration, remember this is the one that is an invisible area of endometriosis. This is a nodule that's easy to fill in the office. The thing's 1.5 centimeters in size, but you can't see it. So this is one of those lesions. After you dissect it, you see the lesion right there. Easy to see once you've got it dissected out, but until it's dissected, you can't see it. And surrounding that's the healthy fat. As you've heard in the last 2 days, fat is our friend. We like operating in fat, but the rectum drops away from it and we're okay. When you look at the lesions themselves, there's healthy fat surrounding it. There's about 85% of the lesion is fibromuscular scar. It's a fibromuscular metaplasia that happens as a response to the infiltrating endometriosis. And I use the word infiltrating because I mean it. This is not a non-infiltrating lesion like a fibroid, which is an expansile lesion. This doesn't have a cleavage plane around it. You hope you can find where the planes end and where they don't. If this were expansile, there'd be a cleavage plane around it. This is infiltrating. The glands and stroma and recent bleeding are the little red dots, and old hemorrhage is the black. So now we come up to Kuhn in 1982 and Virtualini in 2000 and Ron Batnine in 2001, so that finally we catch on to the fact, Kuhn caught on to it in 1982. The rest of us are slower. The vagina extends to the middle third of the vagina, 93% of patients. So I finally get stage 1 right with the cul-de-sac below it. So the cul-de-sac and the septum are low. Stage 2 is there, with the septum right there. Now, what's wrong with that picture that the Japanese don't like? Septum's not in that last position. So we have this as the original. The cul-de-sac is that yellow area. The septum's the blue area. And we thought that it stretched when you got the deep rectovaginal thing that would stretch the septum out and pull it with us. Now that was a postulate. We guessed that. We had no real data for that. We didn't have observations. So we were there. We thought that was the septum, but the Japanese told us it wasn't. Septum's really still right there. And if you look at their pictures, which they have really good MRIs for, there's the lesion. That's still the septum, right where it's always been. It hasn't stretched at all, and what fills in is loose connective tissue. So when these things stretch up on the Japanese thing, we didn't stretch the septum, we fractured it. It fractures off the septum, pulls up, leaves you loose connective tissue behind. Finally to John Sampson, for whom we owe most of what we do today. All the rest of it's preliminary. Most of us give him credit for really inventing and coming up with what we said. Joseph Meigs, in 1926, called John Sampson the discoverer of endometriosis. And what was John Sampson's response? No way. Pick did it in 1905. Rokitansky did it in 1860. So although we give Sampson a lot of credit, Sampson would have credited Pick in 1905 and Rokitansky in 1860. So everybody builds on everybody else. Everybody looks at things and has to come along with additional information. But what he did do was look at endometriosis almost the same way we look at it today, with very little difference. He'd take pictures like that and he'd see chocolate cysts and blebs and infiltrations, and all those lesions that we see today were published in the 1920s. We've gotten a little more sophisticated than him, but we haven't really added much to what he said. John Fallon in 1950 talks about those little clear blebs. Amenorrheic endometriosis is what he calls them. Endometriosis that hasn't bled. Carl Karnacki by 1969 is talking about transitions from water blisters to dark scarred lesions. And he said it took over 10 years. So these are all slow transitions. All this data really predates what we did. Now, as those of you who read my 1980s articles, you realize that by 1988, I'm up to 20 different descriptor types. And if you look at the very last one, it's still other. Okay? I still can't figure out what to call them. ASRM comes in 1996, and as we talked about yesterday, when they published this, everybody comes to the conclusion all these types are endometriosis. Remember, none of these types are always endometriosis. Even the dark scarred lesions, at first laparoscopy can be wrong, and at second laparoscopy can be really wrong because foreign body kicks in. But those were my pictures, so I do have to take responsibility for them. From the talks yesterday, we talked about powder burns. Remember, the first one is a dark scarred lesion, where the dark part inside is the old trap blood. The second one, the vesicles are the endometriosis. The brown is hemosiderin and iron. For those of you who were here yesterday, what I want to try to do is, we talked yesterday about which one do you think it is. Today we want to take it one step further. Which one do you think it should be? So what I want to know is a powder burn A only, B only, either one, neither one? I've confused you anyway. How many of you in this day and time would say that it has to be A? 2. How many would say it has to be B? 1. How many of you think it can be either one? 1 or 2 or 3 or 4, a whole bunch, 10, 11, 12. So, and neither, who wants neither? Now we got a couple of neithers. We're going to have powder burn as something else. Remember, we have terminology that we don't even have good definitions for. We just use these things. Now, what David Redwine did in 1988 and Ken Severno and Bob Albee and Fisher did in 2008 was they didn't worry about they didn't worry about all my 20 descriptors. They went to, if it's visually normal peritoneum, then it's okay, but if it's visually abnormal, it's not. And in that classification, in that definition, they talked about smooth, non-disturbed peritoneum with no fibrosis and no scarring. The vessels were normal. There's no neovascularity, no radiating vessels, nothing aiming at a target tissue. The peritoneum was transparent and there was no color contrast. There was nothing coming through it that interfered with your light. There were no cysts, no subperitoneal cysts, nothing that looked like an abnormal event below the peritoneum. And there was no surface or subperitoneal fibrosis. And probably the only study that I know in the literature that even begins to look like starred, they published the one on laparoscopic appearances in 2008. And in that study, in appearances that did not have a specific classification, but had an abnormal appearance, they found endometriosis in 24.3% of those. If you remember from my talk yesterday, we talked about I had a 15% false negative rate. This is the same thing I'm talking about, and I trust their number more than mine because theirs was prospectively determined by criteria, and mine was it just happened to me. So if you look at this, I have a 15% false negative rate, and the question would be is if I followed their criteria and got 24% here, would I still have a false negative rate because I'd have classified things otherwise? But if you're not getting a false negative rate and you're not biopsying things that you think are not endometriosis that turn out to be endometriosis, then you're missing things. If you're doing biopsies and the pathologist tells you that it's cancer and you believe it's endometriosis, we have a major problem. Pathologist calls it cancer, it's cancer. Now, when pathologists call it nonspecific inflammation, lymphoid aggregates, subperitoneal cysts, endosalpingiosis, psammoma bodies, those kind of things, then I'll leave it up to you what you do. I'm going to believe the pathologist. If that's what they call it, that's what they call it. I kind of think the pimple model is the best model for all of this stuff. In looking at a pimple, we can look and tell somebody what looks bad. We can't tell them what hurts. They come and go. They have their own patterns. Some go away by themselves. Some need medication. And dermabrasion is sometimes used. So the pimple model is the one I like for most of this stuff. We'll talk about theories just because we've gotten to hear Harry talk about theories. I pulled some slides. These are all the theories that I generally talk about. If you notice, about 2/3 of the way down the list, we have mularionosis 1, 2, and 3. And if you don't understand mularionosis 1, 2, and 3, it's difficult to even talk about Mullerian theory. 1 is embryonic rest. 2 is hamartoma formation, which probably doesn't come in. That's more like having a fibroid in the uterus. And 3 is choristoma, which means it's out where it doesn't belong, but we don't understand why. So if we look at retrograde theory, remember retrograde theory says the initiating event is desquamation of epithelium from the endometrium, which goes retrograde through the tubes. It disperses into the peritoneum, attaches to the disperses through the abdomen, attaches to the peritoneum, and then to become endometriosis, it infiltrates and grows. And if we believe Ivo Brosen's, it has to grow to a certain depth, or we shouldn't call it endometriosis. He doesn't believe we should call these little superficial blisters endometriosis for reasons that are obvious to him that aren't obvious to me. The timeline for that, initial attachment takes anywhere from 1 to 24 hours in the lab. Dark scarred lesions take 4 to 7 years to develop, and the large nodules are anywhere from 4 to 20 years to develop. These things don't come up very fast. So attachment, infiltration, and growth. To be able to do all this stuff, we have to have a failure to clear the cells. The body's natural response to endometrium in the peritoneum is to clear it. And it probably does that quite effectively 85, 99% of the time. When it doesn't, then it can grow. And it doesn't clear that it may be decreased apoptosis. The programmed cell death doesn't always occur. There's an altered immune response. Some sort of peritoneal inflammatory response, whether it is a retrograde menstruation is the initiating event, primary peritonitis, sexually transmitted diseases, something that irritates the pelvis, and an abnormal autoimmune profile. And what I need to do is work all that genetic stuff in that we heard in the previous talk into this, because it belongs in there somewhere. And then the last is an age-dependent immunity development. Teenagers don't clear it as fast as adults clear it. So retrograde menstruation goes back into the pelvis, and once you're into the pelvis, that's the diaphragm. Ready access to all the bowel, the appendix, diaphragm, and the lungs. It can infiltrate into the sciatic nerve. So you give me anything in the pelvis, bowel, bladder, appendix, vagina, sciatic nerve, diaphragm, lungs, I can explain it on retrograde menstruation theory. I can't use Mullerian to pick up anything but the pelvis. Mullerian is in the pelvis. It's not any of those other areas. Only way I can get Mullerian to go into the pelvis is desquamation has to come from the endometriosis in the pelvis and then disperse and attach elsewhere. It's an aberrant form of Samson's theory. But if we look at that, we get endometriosis in the diaphragm that can directly infiltrate into the lower lung fields, or we get all this little foramen in that or what we think are responsible for ovarian pulmonary metastasis. Any of those cause that to happen. So theories, I need Samson, and then I need a few other theories. For surgical scar, I have to have direct implantation. I have to have immune competence and development of immune competence so I can explain differences between where it is in teenagers and where it is in adults. The induction theory, because of Marsh and Laufer's paper and because of Cabana's paper, those look like induction. And then, boy, we get off to the distal sites, eyes and spinal column. We either use Mullerianosis 3, which is choristoma formation, and it basically says it's there and we don't know why it's there. It just is. Or we have to use lymphatic spread, hematogenic spread, or something along that line. You can't use standard Mullerian theory because those are not Mullerian organs. That was too fast a conclusion, wasn't it? In conclusion, some of these are new slides. I was not quite sure of the timing. We'll have time to ask questions. In conclusion, as we know from MC Escher, not everything that we look at and think we see is what we think we're looking at. In the long run, we're going to have to study more, get more knowledge on endometriosis, look deeper, so that we can understand this very complex and enigmatic disease. Thank you.